Okay, good morning everyone. The topic we're presenting is called Subscapularis Management and Open Shoulder Surgery, and this is based on a JOS article that appeared in 2008. So shoulder procedures are, I think, becoming more common in current orthopaedic practice, and that can be attributed to a range of things. New patient positioning techniques, which make visualisation of the shoulder more agreeable to the surgeon. There's a greater range of products to use for shoulder procedures, both elective and trauma. Things such as the advent of the Peel plate made treatment of shoulder trauma more practical. And advances in arthros, what can be done arthroscopically, have made shoulder surgery more approachable for many surgeons. So correspondingly, we'd expect an increase in the use of surgical approaches to get to the shoulder joint. Now, the anterior approach, or the delta pectoral approach, is really the workhorse of shoulder surgery. Hoppenfeld tells us that the uses for the open anterior shoulder approach to the shoulder include arthroplasty, tumour work, fixation of fractures, reconstructions for dislocations, and joint washouts. I might point out that the last two uses for this approach are increasingly done arthroscopically where able to minimise soft tissue disruption. And the treatment of fractures may not necessarily rely on the detachment of subscap to visualise the joint. The fracture itself may have damaged subscap and left the joint visible, and most surgeons will try and leave the rotator cuff on and just set a plate over the top of the insertion of the rotator cuff. So, when doing the anterior approach, the landmarks of the tip coracoid and the delta pectoral groove, you make your skin incision, try and preserve the capellic vein, though I find this quite difficult to do. Retract the vein medially or laterally. I think medially is more traditionally described. Move, after finding the conjoint tendon, move this medially, and then you'll have reached the clavipectoral fascia overlying the subscapularis. This is the point where you need to consider how it is that you're going to enter the shoulder joint. Subscapularis arises from the anterior part of the body of the scapula, moves forward to insert into the lesser tuberosity of the proximal humerus. 2/3 insert into the lesser tuberosity, and the inferior 1/3 insert into the shaft of the humerus. This is a nice little anatomical specimen I found in the literature showing the innervation. These are the upper and middle branches of the suprascapular nerve arising from the posterior cortical brachial plexus. This patient's got a branch arising from the thoracodorsal nerve as it heads posteriorly. So, the commonly described method for removing subscapularis to allow visualisation of the shoulder joint is to identify the superior border of the tendon and subscap, and then identify the inferior border. Is usually landmarked by the anterior branch of the circumflex humeral artery and its vena comitatis. Using a blunt instrument to protect the axillary nerve, which is approximately 25 to 30 millimetres away from the inferior border. Slide another blunt instrument between capsule and the tendon and subscapularis, and then perform the tenotomy approximately 1 centimetre away from the insertion of the humeral head. But as the junior registrar's knife passes through the tendon, take a moment to think about the function of the subscap and the potential consequences of performing that tenotomy. So, the role of subscap isn't just a simple internal rotator for the rotator cuff. In certain positions of the humerus, it will actually act as an adductor or an abductor, has an important role in stability of the humeral head, acting as a primary anterior stabiliser, and also acting as a humeral head depressor. It's very important in rotator cuff synchronicity. So it's part of the transverse force couple across the humeral head, balancing the role of the power of the external rotators. After it's been tenotomised in open shoulder surgery, the subscapularis will take one of two paths. most of the time it will heal, and a small percentage of the time it may not. And if it does not, it may be associated with poor clinical outcomes for patients. And this has been the subject of scrutiny in the shoulder literature over the last decade or so. Subscap failure has been attributed to the failure of rotator cuff repairs, fatty infiltration and rupture of subscapularis itself, patient weakness, consequently smaller tendon and smaller insertion footprint, and instability of total shoulder replacements. Suggested risk factors for having a subscapularis dysfunction are patients that are multiply operated. For example, revision shoulder procedures. Those patients that have poor quality tissue to begin with, and those patients that have suffered post-operative trauma or have been poorly compliant with your gentle rehabilitation regimen. It's been suggested that insufficient repair at the time of surgery or that subscapularis lengthening techniques may compromise the strength of the subscap after surgery. Or if you use a glenoid or human head component, which is too big. So with all this in mind, what other techniques can you do to attenuate any potential damage to subscap? You can modify your open approaches, so instead of doing the tenotomy, which is classically described, you could do a subscapularis peel. You could do a transverse split in the line of the fibres. Or the other option is that you could do a lesser tuberosity osteotomy of the humerus. And bearing in mind the big picture, you could consider arthroscopic procedures for your patient. So I'll describe the subscapularis peel first. In some ways, this seems to remind me of the hard hinge of the shoulder. So essentially what you're doing is peeling up the tendinous insertion of subscapularis from around the anatomical neck to the less tuberosity. This allows you access to the joint for your shoulder surgery, and after you've completed your procedure, you can use intraosseous sutures to hold it back down again. The authors of the AAOS study suggested this wasn't a good procedure to do if you're aiming to do stabilisation, because in those situations you won't preserve the insertion of the subscapularis tendon. But it does, if you have an internal rotation contracture, allow the subscap to be medialised. The other procedure that you can do is a lesser tuberosity osteotomy, and here essentially what you're doing is lifting off the tendinous insertion to the proximal humerus. To give you access to the lateral side of the lesser tuberosity, you can consider doing a biceps tenodesis. You cauterize the anterior circumflex humeral artery, put the patient into abduction and internal rotation to bring them to view, and then you raise a flake of lesser trochanter, aiming to be about 3 or 5 millimeters thick with 3 to 4 centimeters long. Afterwards, you can use a variety of repair options, including transosseous sutures. You can use a small plate of screws or a single screw or cerclage wire. If you've used a prosthesis, there may be holes in the prosthesis for you to secure it to with the sutures afterwards. The transverse split, here you're trying to go through the upper 2/3 and the lower 2/3 of the subscapularis tendon. And it's a multi-pennate muscle, and so you can identify, I'm told, from my reading it indicates, you can identify these separate little muscular tendinous units, and you aim to split it down through the centre there. The authors of the AAOS article suggest this is appropriate to use for instability surgery. And then with any description of access to the shoulder joint, there's a lot of other variations. For example, instead of doing a full tenotomy, you can do a modified L shape, which leaves you intact the lower 1/3 of the muscular tendinous unit, and the thought preserves the arterial supply and also some proprioception to the shoulder, at least for that muscle anyway. A full subscapularis takedown is described, all the way down to the level of latissimus dorsi, and I found one article talking about doing in addition to doing your tenotomy, doing a 360-degree release of the insertion of subscap This is more a procedure for patients that have developed significant contractures after, for example, glenohumeral osteoarthritis. And so after doing your tenotomy for subscapularis, what are the results? And the answer to that seems to vary depending on what procedure you're doing. So small numbers observational studies, some are simply cohort studies, some are case cohort studies comparing, say, the L-shaped tenotomy versus a transverse split. In general, I think it's fair to say across all these studies, those that looked at tendon quality noticed an increase in fatty infiltration of the tendon and smaller tendons compared using a complete tenotomy or versus using a transverse split where the fibres aren't incised transversely. If you did do a transverse split, the patients tended to have slightly better outcome scores in this study, at least one of the scoring systems, and slightly better satisfaction. And in general, if you did a tenotomy of subscapularis, your patients tended to have evidence of subscapularis dysfunction on clinical testing. So we all know Gerber's lift-off test and the belly press test. These are the two clinical tests which are utilised for these studies. When we look at the outcomes for total shoulder replacement, we're tending towards some bigger numbers here. After using a complete tenotomy technique, these authors found a 3% incidence of instability, and when they did a second procedure to do direct visualisation of the tendon, they found that subscapularis was not intact. Smaller numbers, they found a similar finding to those with instability surgery. If you had a complete tenotomy of subscapularis, this is a true osteotomy, you had clinical signs of subscapularis dysfunction. Evidence of fatty infiltration with the lesser osteotomy. And in this multi-center study of 550 total shoulder replacements, they found that if you did do tenotomy of subscap, you had fatty infiltration of the tendon and a negative impact on mobility, patient strength, and clinical outcome score called constant score. So based on the reading of the JOS article, they've kept it safe and made only a few recommendations. They suggested doing a meticulous repair, performing preoperative evaluation of the tendon quality using a study such as MRI, although it didn't offer suggestions on how to adjust your procedures if there were patients did have poor quality tendons. And then recommended that any repair that you do had high internal fixation strength, minimal gap formation, and stability, and the patients were held stable until tendinous healing. Their opinion was that although there was a high incidence of clinical dysfunction as witnessed by the change in the clinical testing, they didn't think that overall corresponding to patient function. And they also felt that functional scores for arthroscopic instability procedures were equivalent to open instability procedures, which seems to be some conflict about the literature. From reading, contrasting with some other articles for perspective, other authors are a little bit more concerned about the fate of subscap after a tenotomy, and they've offered some other methods for performing shoulder replacements and instability repairs. In general, the flavour was that if you wanted to do something like an open lattier, using a transverse split instead of an L-shaped tenotomy there was evidence for in the literature. And if you were performing a total shoulder replacement, the lesser trochanter osteotomy was the access of choice, although these were described. These are my references. So again, as I was saying, this JOS article paints a very rosy picture of subscap tenotomy, whereas this German review, which is published at a similar time, is a lot easier to read, and I find gives a much more intuitive insight into this issue. That's it.